I'm a master's licensed alcohol and drug counselor, and I've worked in this community for upwards of about 20 years with our substance using population. So we're going to talk today about several things that I'm hopeful you will take from here and maybe have some challenges for yourself for how you look at the disease of substance use. But first, we're going to talk about my dog. So we have a 1-year-old black lab. Her name's Callie. She's a mix, and we rescued her last year. And she's really cute. And if you have a black lab, then or lab at all, you know that they have this lab mentality, right? Very food-driven, very happy. She's also really eager to play tricks for you and do things for you, especially if you have food, right? And so I want you to think about Callie. If she hears something that she thinks is her bag of bones, right? She comes running. It was just a noise. It was just a sound. She comes running. Generally, she comes running around from the living room to the kitchen, and her legs are sort of flying out from under her, right? Because she's trying to turn the corner quickly. She comes to me. She'll do just about any trick in the book. It really isn't very many tricks that she has. But she'll do all of the tricks that she knows so that she can try to get the treat from me, right? Sounds familiar. We have dog owners in the room, people who love dogs. Sure. So let's talk about what happened. She heard a noise, right? And her brain told her body, I'm getting a treat. And her brain and her chemicals all started surging, right? And one of the things that she does when she gets to me is she's drooling, even before she's made it to me. Her brain told her body, I'm getting a treat. And chemically, her body started getting ready for that treat, right? And her brain chemicals went to her stomach started churning, and all the chemicals in her stomach started coming on up her esophagus, and it created drool. She doesn't drool because she thinks that I think it's cute. She drools because her body had a chemical reaction to a noise. That's all it was a noise. It could have been a stack of Ritz, right? It might not have been her bag of bones. But she reacted to that. You're probably all saying to yourselves, I thought she was going to talk about drugs, which I am. But I want to make a point here is that we chemically react to things like a noise or a substance. And I want you to compare that to what that would be like when it comes to substances. People's bodies react. We get used to this idea of a reward when it comes to a substance. And what happens for my dog is not unlike what happens for any of us when we drive down Union Ave and we smell Hamburger Alley, right? We smell French fries. Ooh, I'd like some French fries, right? Or if you're someone who likes chocolate and you saw chocolate on the table, you might say, ooh, I like chocolate, right? And our body gets ready for that. If you're someone who likes to exercise, your body might react to the idea that you're getting ready to exercise. Our chemicals get moving. I'll stay over here. And so I want you to think about this. We have this sort of reward pathway in our brain. And what we learn at a very young age is that there are certain things that make us feel good. And our reward pathway kicks into action when something makes us feel good. We get rewarded for that. And we get used to this idea. The pathway sort of gets worn. Kind of like if I walked a circle on this rug, it would get worn. And so someone like Callie, right, she knows there's a reward for doing things the way I want her to do them, and she gets that. Her reward pathway has been developed. And so we have these neurons in our brain. We have like a bazillion of them. I actually don't know how many we have, but it's got to be somewhere around a bazillion. And some of those neurons are meant to create feel-good chemicals. Some of those neurons are meant to receive feel-good chemicals. And so what happens when we do something like exercise or eat chocolate, those feel-good chemicals kind of kick into action. And one neuron releases them, one receives them, and we say, yeah, that feels good. And then the reward pathway says, let's do that again. We like that. And so we learn over time what feels good. And what happens when someone uses a substance that's, 10,000 times more powerful than chocolate, say heroin or cocaine, that pathway gets set into a motion in a way that we can't understand if we haven't been there. It's very, very powerful. And so substances, the ones that we have out here today, it's like having two keys that fit the same lock. So if you think about what happens with something like heroin, it goes into the neuron and it basically says to the brain, you know what, I can do this job. I can do the job of the dopamine. You're not really needed here anymore. And the dopamine sort of gets the message that it doesn't need to do what it needs to do, what it used to do. So over time, what happens is substances can sort of take over those feel-good chemicals. I want you to think about what we say to people when they first decide they're going to get well from substance use. We say things like, go for a walk, you'll feel better. You know, pull yourself up by the bootstraps, right? We should not be saying those things anymore, because when we're dealing with someone who's made the decision to get well, they've really eliminated a lot of the chemicals in their brain that they can use to feel okay. They're not there. We have work to do to get those back. So when we think about the science of addiction and what actually happens in the brain, we sort of have to understand that the neurons and the science of addiction before we can start reducing the stigma around it. Because we make a lot of statements to people who have substance use disorder that are very simple. And because we're thinking more rationally and we have all the chemicals that we need, it's easy for us to say people should just get well. People should just stop. People should just make the decision to not do that harmful behavior anymore. When really this pathway that's been developed is very, very difficult to change. And so one of the challenges for you today is to start to see this as the disease of substance use disorder. We really need to change our language, and that's one of the things that we're trying really hard to do with Stigma, is change our language around how we look at this disease. Here in New Hampshire, we have some things that are happening. We're doing a lot of work on how do we reduce stigma in our hospital settings. And some of the work that we're doing there is stuff that I challenge people to do all the time. When we call someone a junkie, a pill seeker, when we use language that is really derogatory, we don't help them to get well. We just keep them stuck in that same spot. Stigma is the #1 reason people don't seek treatment. Let's think about that for a second. Stigma, which we create, is the #1 reason people don't go to treatment. If we could get people to go to treatment, we'd have a whole lot less problems. Here in New Hampshire, we are unfortunately the 3rd highest in the state for overdose death rates per capita. So that's a big place to be. We don't want to be there. And so we have some work to do. We have a lot of work to do on how we manage this disease, how we provide treatment, and what we do for people. So like I said, in our hospitals, we're doing a lot to manage how we train our staff, how we approach people, how we encourage them to get to treatment, and what we have for treatment available. It's big stuff. It's really good stuff that's happening. So some of the things that we're trying to do is we're trying to help our general public understand that when it comes to diseases, the challenge is to say what other diseases have sort of behavioral pieces as well, which is a lot of them, right? A lot of the diseases we have to make behavioral change to be well as maybe taking medications, right? When we think about the common example we always use is diabetes, right? Diabetes, we have things that we need to do to help people get well. There may be medications they can take, there's education we can provide, but very often people have behavior change they need to make in order to be well with diabetes, right? They may not be able to be in the same places anymore. They have food they need to change, and maybe even people and places they need to change, very much like addiction. Heart disease, very often lung cancer, right? These are things that people may have behaviors that they need to change in order to get well. So one of my challenges for you today is to consider the last time you tried to make a behavior change around something in your own lives. It went perfect the first time, right? That's what I thought. Probably not so much, right? Yet we have this expectation when it comes to the disease of substance use disorder that people are going to make a decision to get well and it's going to go perfectly. They're going to do it great. They should never make mistakes. It should just go perfectly well. And then when they relapse, we go, oh, you don't really want this, do you? And we shame them for it. Yet when we make changes in our lives, we make mistakes. I know I do. We make mistakes all the time. And that's part of learning, right? That's part of our process. One of my favorite things that I tell my clients sometimes is Babe Ruth hit a lot of home runs, but man, he struck out a lot too. And we have to strike out to hit home runs. We have to. And so we have to start to look at how we manage this differently when we encourage people to go to treatment with the understanding that it's probably not going to be perfect. So There's a couple of other things that we're trying to do. One of them is what we call harm reduction. And if you haven't heard of that term, really it's an idea of changing our mindset from things need to go perfectly when someone decides to get well to how do we make it better for them? How do we get so that someone who is using IV heroin every day is on the path to getting better? Maybe they're still smoking pot. Maybe. But how do we get them to that place where we see that their lives are improving and they're starting to get better? And so we have things like needle exchange programs. I know it's a hard concept sometimes for us because it feels like we're giving out needles to people so they can use. But honestly, the communities in New Hampshire that are doing needle exchange programs had a much nicer spring cleanup than we did. And it's important for us to consider that. They're also lowering their rates of hepatitis C and HIV and other infections. And so those are all really positive upsides to needle exchange programs. Something for us to consider. We're also doing things like medication-assisted treatment, which is providing medication for someone in early recovery so that they can start to get well. And that's a topic I'm pretty passionate about. We often hear people say, that's cheating, that's a crutch. People are just switching one drug for another. And you've probably heard those things as well, right? And so here's my challenge to you today, is we use medications with all the diseases out there. We sometimes say to someone when they come into the emergency room, with the disease that's out of whack for them, we're going to give you some medicine. And somewhere down the road, when you've had a chance to make some behavior change, we might even get you off that medicine. But today, we can start helping you get well. Here's a medication. What we see with people who start medication in programs like we have in our area is that within 1 week, they're starting to pull their lives back together. They're starting to get jobs, take care of their kids, and do well. And I'll tell you, when I see people switch from one drug to another, when they stop using heroin and they start using cocaine, they're not taking care of their kids, and they're not getting a job, and they're not pulling their life together. This is not switching one drug for another. This is starting to get well, and it may take a medication to do that. The other thing we always hear about medication in early recovery for people with substance use is people are always saying, when are you going to stop taking that medicine? And I got to tell you, in the past 6 months, I've had 3 patients that have stopped taking their medication because of the pressure that they felt from their employer or their family. And all 3 of them are gone. And that's not okay with me. If you're on a blood pressure medication, did anybody ever ask, when are you coming off of that? No one's ever asked me when I'm going to stop carrying my inhaler with me. We don't ask people when they're coming off their Lipitor or their insulin. We don't. We say, good for you for getting well. So we have to change our perspective on how we're looking at the treatment that we do in substance use disorder, because some of it's working really well, yet we tend to stigmatize that and make it worse for people. And we don't want to do that. When we help people connect to treatment and we stop stigmatizing them, be that in the waiting room of the emergency room, be that in the rooms that they're being evaluated in or in our hospitals, when we stop stigmatizing them, we increase their chances of connecting to treatment by over 50%. It's an important statistic because we really want people to connect to the treatment services we have in our area. And so my challenge to you is, there are some things that you can really be aware of in your own communities about how you look at this. When we start seeing this as the disease of substance use disorder, and we stop calling people an addict or a junkie, we increase their chances of saying, I can change, I can do something different, I can get well. So we are all part of that. And you know, over the years, the more I talk to people, and the more times I spend time with people like all of you, the more I find that there are less and less people who haven't been touched by this. We all know a family member, a friend, a kid in our school system, right? Everyone's got a niece or a nephew, a parent. This knows no bounds. People of all ages are affected by this. People in all places, in all jobs, people are affected by this. And so we have come to a new place in our conversation around this where we say, I have to stop saying that I don't get what that's about, because I'm part of it. We as a community, we are all part of helping people with substance use disorder get well. By changing how we look at this, by changing our attitude towards it, and by lowering the stigma, we can help people get well. And treatment works. It truly works. I wouldn't still be doing the job that I do if people didn't get well from it. And so it's really important. When I have a client who comes back to me, I had one this week, came back to me and said, you were my counselor 10 years ago, and today I am married, I have a full-time, really good job, my second child's on the way, and I'm still going to meetings, and I still keep in touch with people, and I'm doing really well. There are lots of those stories, lots and lots and lots of those stories. When we see our headlines and our newspapers only sort of highlighting all the difficulties we're having with substance use disorder, we tend to forget that there are lots and lots of stories of people getting well. Treatment works, and we are all part of helping people get there. Thanks for listening.